Welcome. We're here with Dr. Greta Bernier. We're talking about colorectal cancer, and I'm going to ask her to introduce herself.
Hi everyone, I'm Dr. Greta Bernier, as she just mentioned. I am one of the colon and rectal surgeons here at Valley Medical Center, and I'm excited to talk to you about this important subject.
How does colorectal cancer screening save lives?
It saves lives in a couple of ways. The first one, or the first thing to know, I guess, is that colorectal cancer is the third most common cancer in both men and women, and the third most common cause of cancer-related death. And so anything that we can do to prevent it is important, or decrease it. And with screening, with colonoscopies or other types of colorectal cancer screening, we can find what are called polyps, which we'll talk about later, and remove them before they ever become cancers. And so we can save lives by stopping a cancer from ever happening. And then the other thing we can do is with screening, we can find these cancers when they're early. Maybe somebody doesn't even have symptoms yet, but if we see them, then we're treating a much more early stage, much curable cancer. And with screening, what we've noticed is that overall the incidence of colorectal cancer and the death or mortality rate from colorectal cancer has gone down. So it's really an important tool and has been a kind of a game changer for this type of cancer.
Many of us have learned that there were new screening guidelines and age recommendations. Can you tell us more about that?
Absolutely. So I just mentioned that the incidence and the mortality rate are going down overall, which is good and is true. Unfortunately, what we're seeing is that the incidence or the rate of identifying colon cancers is going up in our young patients, so those under the age of 50, and that their cancers tend to be more aggressive or more advanced when they are found. So the guidelines in the past were for people to start colorectal cancer screening at the age of 50. And in 2018, the American Cancer Society and some of our surgical societies recommended that that age be lowered to the age of 45 to respond to this, what we're seeing in these younger patients. If you do have a family history or a personal history of cancer or polyps or other GI disorders, then it may be earlier than 45, but in everyone else, average patient would be age 45 now.
What are the options for screening, including the stool card and colonoscopy? And can you explain how they each work?
So the stool card is something that you would take home with you and put a stool sample on and then send in. So it's pretty straightforward in that way, and you typically do it every year, maybe less than that depending on which exact test you were using. And then a colonoscopy is an actual procedure at a facility where we use a small flexible camera and put it into the colon and then look at the colon all the way around at the lining on the inside. So we're, instead of looking for factors that might show that there's a cancer, we're actually looking directly for polyps or cancers on the inside. Because it's not comfortable to do that while you're awake, most people choose to do it with sedation, and we always offer sedation, and typically with an anesthesiologist who's there with you during the procedure so that we can do the colonoscopy while they're watching your heart and lungs and making sure that you're nice and stable. It's a sedation, not a general anesthetic, so you're not put completely to sleep. You don't need a breathing tube in. You do need someone else to drive you because you're not safe to drive for the rest of the day. And then you need to do, in preparation for the procedure, since we're going in there with a camera to look directly at the lining, we need all of the stool to be out of the way. So you do what's called a bowel prep in the day and sometimes part of the morning before to make sure everything's cleared out.
And what are some considerations and limitations with each of the tests?
So this is important because, I just described the two things, and one sounds a lot more complicated than the other, right? Putting a stool on a stool card and sending it away is much less coordination than doing a whole colonoscopy. But there are really important differences between them and why the colonoscopy is considered that gold standard test. So a stool card is looking for blood in the stool, remnants of blood, other factors that could be associated with a colon cancer or a polyp. But it is not as accurate, so it can have what we call both false negatives, meaning you get a negative test result back, but you actually do have a polyp or a cancer and it missed it, or a false positive, so it sees something abnormal, but there's actually nothing there. If you get that, so one, we don't want to miss anything, but two, if we get that false positive, then when you go in for your colonoscopy, it's considered, which is the next step to look for that thing the test was showing, you have to get what's called a diagnostic colonoscopy. Now, from your experience, it's the same, but importantly, there's a big difference in what insurance companies cover. So diagnostic colonoscopies tend to be much higher out-of-pocket cost for patients. So we would want them to know that and talk to their insurance companies before they went the stool card route to make sure that they didn't have this big cost at the end that they didn't expect. Colonoscopies are the most accurate. We can see everything very well, and they have the benefit of being both diagnostic, meaning we can find something, but also therapeutic. So if we find a polyp, we can take it out. If we find a mass, we can biopsy it. So you're already there. And then if everything looks great, you don't have to do that whole procedure again until 10 years later, whereas the stool cards, like I mentioned, you do every year. So it really is the recommendation that if people are healthy and have no other major contraindications or reasons to not get a colonoscopy, that the colonoscopy is preferred. And then the stool cards are there if for some reason that doesn't fit well with someone's medical issues or with their goals of care.
So what's the big deal with the bowel prep for a colonoscopy? A lot of people talk about how they're scared of that.
The bowel prep is what we use to clear all the stool out. So we said we need a camera in there, we need all the stool to be out of the way so that we can look at the actual lining. So we have to essentially cause diarrhea or cause, the bowels to move faster and clean things out. And so that's why people have a lot of fear about it, or they'll say, that part was much worse than the procedure, because in the procedure you get to just take a nice nap. And so it's not, it's not a walk in the park, it's not fun. But most patients say that it was pretty well tolerated, and the benefit you get in going through that and not having to do it for another 10 years is worth it, so that you can get that good study. But it's not fun. Every GI or colorectal surgeon, every endoscopist will prescribe to you the type of prep that they prefer. But there are all different kinds, and so if you have a preference too, you can always let us know. There are ones that are more volume, up to 4 liters. There are ones that are just pills. There's differences. Most of us here use ones that are mixed with Gatorade. So there's all different types that you can do. So if you have a specific preference, you can also always let us know. Many people will come in and say, oh, my mom did this one and she loved it. So just let us know and we can adjust it for you.
You mentioned polyps earlier. What are polyps and why would they need to be removed during the colonoscopy?
Polyps are an overgrowth of cells in the lining of the colon that we can see. So a little humped up clump of cells, or tissue, I should say. And there are a few different kinds. When we talk about it in this context, we're mostly talking about what are called adenomatous polyps, or adenomas. And those are important because those are the precursor to colorectal cancer. So if those are left alone for years, then it will turn into a cancer. So if we can find those and take them out when they are in this polyp precancerous stage, then that cancer never happens. There are a couple of other types of polyps to know about too. The one type is called a hyperplastic polyp, or an inflammatory polyp, which is just an overgrowth of normal cells. And we may remove a polyp and send it to pathology and they come back and say it's hyperplastic. So that means there's no increased risk of cancer with that polyp, and nothing different we need to do. The third type are what are called serrated polyps, or serrated adenomas, and those do have a risk of colon cancer associated with them. So if somebody has an adenomas or one of the serrated polyps, then we would change how frequently we would do the colonoscopy. So completely normal colonoscopy, you'd get your next screening in 10 years. If there were 1 or 2 polyps and they were small, it would be at 7 years. If there were more, or they had we're larger in size, it might be 5 or 3, and we have guidelines that help us make that recommendation for you as far as what we need to do based on the polyps that we see.
What lifestyle changes can we make to reduce our risk of colorectal cancer?
I would say the first thing is to get a colonoscopy. That's a great lifestyle change to reduce your risk. But I think what you mean is kind of in our daily lives, what can we do? So colorectal cancer is associated or higher risk in our patients that are overweight, so trying to maintain a healthy weight, staying more active. Nicotine use and heavy alcohol use are also associated with risk of colorectal cancer, so quitting smoking, cutting back on alcohol. One that has been discussed in the last few years quite a bit is red or processed meats. The World Health Organization did classify red meats as a carcinogen, meaning something that promotes the development of cancer in our bodies. It's not a big enough increased risk that they came out and said everyone should be vegetarians. It's just one of those things to consider in your overall trying to live a healthy lifestyle is not over-consuming red or processed meats and being mindful of how much of that you're taking in. The other things which can't be adjusted but are associated with your risk is knowing your family's history of colon cancer, rectal cancer, and what age they were when they were diagnosed. Patients that have a family member who was diagnosed in their 80s, that tends to not be a run-in-the-family kind of cancer. But if you have a family member who was diagnosed in their 50s, then that might be, or it might change when we tell you to get your first screening. So you can't change your family history, but to know it is a really important thing.
What are the signs and symptoms of colorectal cancer?
The most common things we see when someone has a symptomatic cancer are potentially obstructive symptoms, meaning that there's a blockage from the tumor, making it hard for stool to get through, that they would either experience as feeling more constipated, maybe bowel movements are becoming less frequent, more narrow in the size of bowel movements, feeling like things are backing up enough that you're feeling bloated or distended, sometimes people getting nauseated. Other thing we talk about is blood in the stool. That can either look like bright red blood, it can be kind of maroon, jelly blood, it can be dark brown, tar-like, so any kind of change in the color of the bowel movements. And then sort of the generalized symptoms that you may have heard of before with all types of cancers like weight loss, fatigue, night sweats. Those are all the main things that we think about when somebody has a symptomatic colon cancer. Now, it's important to know that many of these cancers can be asymptomatic, meaning not showing any symptoms for a very long time, depending on where they are in the colon, especially the ones on the right side of the colon, which is the beginning portion. They may not have any symptoms at all. And so even without symptoms, it's important to continue screening to find these before they become so big that they are causing symptoms.
So what's next? How should we get referred in to get screened for colorectal cancer?
Your primary care provider is always a great place to start. You know, they know you the best and are advocating for you and your health, and so they can send us a referral for a colonoscopy. But you also can reach out directly to our direct access line to get your colonoscopy scheduled. Our schedulers will go through a series of questions just to make sure that there aren't any issues where maybe we would want to see you beforehand. If you have complex heart issues, if you're having GI symptoms that maybe we want to investigate a little bit more, anything like that, then we may say, yes, we're happy to do your colonoscopy, but we want to see you in clinic first and make sure that there's not anything else that we need to be doing also. But if you go through those screening questions and everything is okay, then they can get you set up with one of our providers to get a colonoscopy done.
Great. Thank you so much, Dr. Bernier. We'll have information in our details with the phone numbers and website links for those of you watching and want to learn more.
You're welcome. Bye, everyone.